Welcome to Science of Medicine. My name is Dr. Brad Penley. I'm a PhD analytical chemist and also a physician, and I've been teaching this course for about 7 years. I'm interested in helping people understand and connect what they know already in science as it applies to medicine. People that might be interested in going into medicine, or even those early in their career, might be interested in this. So let's start off with how physicians are educated in the United States. The traditional way has been that students will take a variety of pre-medical education courses. Those are courses in chemistry, physics, some math, biology, English, and then they'll sit for an entrance examination called the MCAT. Once in medical school, traditionally they've had about 2 years of basic sciences, followed by 2 years of clinical sciences. Now that has been changing, and I'll talk about some of those changes in a little bit, to be much more integrated. There are certain licensure exams. The United States medical licensure exam has several steps, and those are taken during medical education. Once you complete medical school and graduate, you'll then do a residency, which will last several years. This will allow you to do something such as internal medicine or surgery. That may or may not be followed by additional training, such as a fellowship training in a specialized area. Now, as people have gone through medical education, the way in which people have been evaluated has changed from a knowledge-based, do you know A, B, C, D, to a competency-based. And I'm going to talk a bit about competency. But basically, no one in my practice has ever come in and asked me, hey, Dr. Penley, I have a cough and fever, and do you think A, I have an infection, B, I have acid reflux, C, my asthma is kicking up, or D, I have allergies. Instead, they ask you as a physician to pull those pieces together to order appropriate tests and to come up with some sort of a diagnosis and treatment plan for them. There have traditionally been several variations of, or levels of testing. Before entrance into medical school, that has been the medical college admission testing, or the MCAT. That's been going on since the 1920s. Current version was in 2015, followed by this licensure exam that I mentioned to you. And then after residency, there are a set of board examinations in whatever you happen to be. I'm certified in internal medicine, so it's the American Board of Internal Medicine. Now, about 20 years ago, people really started raising the concern that medical education and pre-medical education were not really serving people well. There were a number of expert panels that were comprised of people trying to change the way that we educate doctors. In 2009, the American Association of Medical Colleges and Howard Hughes Medical Institute published Scientific Foundations for Future Physicians. And in this, they actually laid out a platform. They laid out a process for educating physicians in the future to be able to give them the tools to be able to solve clinical problems as we went forward. And this really necessitated them being much more integrative in their approach, and the recognition that it was not going to be possible for any physician to know everything, and that instead skillful navigation within the domain of medicine was much more highly sought. So there were several concerns raised about both pre-medical and medical education. In pre-medical education, the science had been relatively static across the past several decades, and it didn't necessarily reflect the competencies needed for success in medical school. And there was also an inhibition in the traditional fiefdoms or towers that people had operated in, chemistry, biology, physics. And so it limited the ability of students to have cross-disciplinary types of courses. In medical education, the basic sciences weren't necessarily tied to the clinical sciences, and it was recognized that instead of just drinking from this fire hydrant of knowledge and trying to memorize all of these things, that it was much better for physicians to actually be able to look up some things that they need to know and actually understand processes as well as some knowledge and have that knowledge, no question. So the impact on this was that it went from moving from a knowledge-based to a competency-based type of curriculum. And they defined certain core competencies for both pre-medical as well as medical students. And then the smart thing that the committee advocated for was a change in the testing, both MCAT as well as the USMLE licensure exam. So I want to give you some examples of this. In pre-medical, there were 8 core competencies that required integration of knowledge across different disciplines. For example, being able to draw statistical inferences from various data sets, to be able to pick up a journal and read an article and understand what it meant, to be able to use your knowledge of physics and apply that to movement within biological systems, or to be able to understand how your vision works based on your knowledge of optics. So this idea of competency is very critical to any profession. In medicine, this has been talked about for some time. It's a habitual type of learning. This idea of a lifelong learner becomes central to competency. And it embodies a set of knowledge, technical skills, emotional intelligence that are used and leveraged to benefit the patient and the community. So this is something that is not something that you acquire in pre-med or medical school. It's a lifelong process, and it requires that you integrate your skills. So I'm going to try to give you an example of what this means. In all of the things of science of medicine, I will base many of the clinical cases on typical kinds of clinical cases. These come about from various experiences that I've had, but are not necessarily focusing on a particular person. So here's a case of a 57-year-old person who had a history of drinking alcohol. And he had stopped drinking about a month ago, but after a recent injury had started back. He was brought to the emergency room by his family after supposedly ingesting about a half bottle of rubbing alcohol. Now, rubbing alcohol is isopropyl alcohol, and you go, why would a person that drinks wine typically drink isopropyl alcohol? Well, some people don't understand the difference between different types of alcohol, and if they say alcohol on the side of the bottle, they might try something different. Currently, the person, when you see them, is obtunded. That means they're not able to really answer your questions, they're kind of sleeping, and they're not very responsive. When you examine them, their vital signs, things like their temperature and heart rate and blood pressure, are all stable. You could rub on his chest and get him to arouse, but he wouldn't really answer a lot of questions. He was not particularly well kept. His mouth showed some dry mucous membranes. His pupils were round and reactive, but by and large, he was having a normal exam. And so anytime you go into the emergency room, you're going to have labs that are drawn. There were a set of labs that were actually drawn also on this person. We got additional imaging, such as a CT of his head, unremarkable, an EKG, which was normal, as well as a chest X-ray. So the pertinent clinical questions are, what evidence exists for this person actually drinking isopropyl alcohol? And if he didn't drink isopropyl alcohol, what other alcohols could he have drunk that might have adverse events for him? For instance, methanol can lead to death. So, whenever a clinician is faced with these kinds of issues, they want to look at evidence. And so the evidence that supports the ingestion of isopropyl alcohol could be direct. For example, if we had the ability to take some blood and measure the amount of isopropyl alcohol in the patient's serum, you could do this by gas chromatography in a thing called headspace analysis. That would be great. It would be a direct piece of evidence. Unfortunately, at this hospital at this time, it was not available. You can look for indirect pieces of evidence, not as strong as a direct argument, but still nonetheless valuable. So you could look at the history as a piece of indirect evidence. Well, the family said so. You know, sometimes people are mistaken. They didn't bring in the bottle that he actually drank out of. So it's a piece of evidence, but maybe not enough to risk this person's life on. Now, in medicine, there are two basic types of decisions that you need to make. You're either making a diagnostic assessment or a management decision. Diagnosis is to collect information and come up with some disease or some process that you're going to ascribe to account for these observations that you have. Management, you already have the diagnosis or working hypothesis thereof, and now you're going to go ahead and come up with what you want to do next. You may or may not have heard of Bayes' theorem. Bayes' theorem is the basis for rational medical diagnostic decisions, and it's based on probabilities. Now, most physicians don't actually sit down and calculate the probability of having one diagnosis over another, but we all understand at the base level that the more pertinent positives you have and pertinent negatives that you don't have, the more likely certain diagnoses are. And you can use this as a way of rank ordering a listing of what you think is most likely. And that rank ordering is called a differential diagnosis. Now in this case, we look at some other indirect evidence. So if I look at biochemical processes, if I drink an alcohol, that is oxidized in my liver. It's processed, and when it does that, it then is oxidized. Now, what kinds of alcohols can I get? I can get methanol or wood alcohol, ethanol, ethylene glycol, as well as isopropyl alcohol. And one of the things that you note is that the methanol, ethanol, and ethylene glycol are all primary alcohols. So if you oxidize a primary alcohol, you go to the corresponding carboxylic acid. Because it's an acid, that leads to what's called a metabolic acidosis. And it decreases the amount of bicarbonate in the person's blood because it's basically a titration. It's being titrated down. This is a medical emergency. It can lead to death and very bad sequelae. Isopropyl alcohol is a secondary alcohol. It's oxidized to the corresponding ketone. It does not produce a metabolic acidosis, so you would expect a normal serum bicarbonate. You can also measure acetone in the blood. So if we go back and look at that evidence from the blood before, we see that this person had a normal bicarbonate, an indirect piece of evidence suggesting that he had, in fact, ingested isopropyl alcohol. You can measure ethanol in a person's blood. In this case, it was nothing. It was zero, undetectable. But the acetone in the serum was large. So these are indirect pieces of evidence that support the hypothesis that this person consumed some isopropyl alcohol. Another piece of indirect evidence is that anything that's dissolved in a fluid, such as blood or such as serum, can create an osmolarity. You may remember from chemistry that there were certain colligative properties. One of the colligative properties was freezing point depression. Another was boiling point elevation, but freezing point depression. And that's based on the number of particles or osmolytes that are actually dissolved in that aqueous component. So we have lots of things in serum that can actually dissolve. Sodium, chloride, potassium, glucose, blood, urea, nitrogen, a lot of things that can actually be dissolved. And they can lead to freezing point depression. And you can measure this, osmolality. And you can also compare that measured osmolality with what is calculated. And this calculation is based on a number of assumptions, but is basically fairly reasonable unless the osmolality is very, very different from normal. And your body has a system, a feedback system to try to keep this very, very tightly regulated. So if you know sodium, glucose, and blood, urea, and nitrogen, you can calculate an osmolarity. Now, acetone and isopropanol are osmolytes, and they are unaccounted for in that formula. So that can lead to what's called an osmolar gap. And in fact, in this person, the osmolality that was measured was 361 milliosms per kilogram, and the osmolarity that was calculated was 296. So the question is, could this come from isopropyl alcohol if this person actually had drunk this? So if you make some assumptions about the size of bottle that the person chose, and you know that it's a 70% volume solution of isopropyl alcohol, then you can convert this into the number of milliosms of isopropyl alcohol that would be in half of a bottle. And that turns out to be a little bit over 2,000. You can then distribute this within the water compartment of the body, assuming that this isopropyl alcohol only is within the total body water. And you can figure out how much is in the plasma volume from that. And if you do that calculation, you suspect and calculate or estimate that the osmolarity that you should have measured is around 347. And that's pretty close to 361 milliosms per kilogram. Maybe the person didn't drink exactly a half a bottle. I didn't do the calculation for how much of the isopropyl alcohol went to acetone and the small difference in that case in molecular masses. But not a bad thing that would support this. Again, indirectly. I had other indirect evidence that I could look at, and I could say, well, the person did have an altered mental status. If you look in the back of his eye, he did not have swelling of his optic disc, which would be expected for methanol, or changes on his CT that would be expected for methanol. There are other substances that can cause an osmolar gap, but not metabolic acidosis, such as glycine and mannitol, but these are hard to come by for the average person. So I point this out to show you that you can use your knowledge. You can integrate what you already know to be able to bring that to bear on patient care. And this course is really about that. That's what I hope that you develop across this time. That's what I'm going to try to work towards to help you do. And so if you follow along on this, and if you'd like to do this, go ahead and subscribe, and I'll post various videos of different types of things that are done in this course. But try to work towards developing the ability to extract pertinent information, to integrate concepts, to be able to apply those concepts, whether they be science or mathematics, to solve actual clinical problems. And I'll give you some practice and show you some tricks along the way. This might be of use to you if you're early in medical school. It might be of interest to you if you're in pre-med. For example, if you had an influenza test, I gave an example here of a quick view influenza test, and it has certain characteristics, sensitivity and specificity. You do a flu swab on a person in October where the prevalence of flu is very low, and you get a positive result. How do you interpret this? What does it mean? It doesn't mean if you get a positive test that the person has flu, because as we'll learn about, those tests can have a certain probability of that positive test being true versus not being true. Another example, a person with pneumonia is unable to breathe for themselves and have to be mechanically ventilated. You intubate the person, you put in a breathing tube down them, and you place them on a ventilator with certain settings, fraction of expired oxygen of 70%, tidal volume of 500 milliliters, a ventilatory rate of 8 breaths per minute, and then you check an arterial blood gas. You take a little bit of blood and you measure certain things, like the pH, like the bicarbonate, PCO2 and the PO2. And so I give various measures for this. What's the best problem to then correct that person's respiratory problem? You have to be able to identify what the respiratory problem is. You have to be able to use the data and your knowledge of physiology to be able to do something like this. Physicians many times will read articles in the primary literature, but you have to make sense out of it. For example, congestive heart failure caused by systolic failure results when a person's heart is unable to pump blood effectively to the person's body. A New England Journal of Medicine study determined a medication, digoxin, if this could be used to reduce mortality or hospitalizations from congestive heart failure. I give some details that are taken actually from this article about how many patients were in the study, what the results were, including the statistical results. What conclusions can you draw from these based on the statistics that are up there? So these are skills that are critical for a clinician to be able to practice. And I'm going to let you in on some secrets in terms of how you can try to develop those skills yourself. Now, a few things. First off, although I am a physician, I am a doctor, I'm not your doctor. And throughout this course, I am in no way giving you medical advice. That is not my intent. So please don't post things that ask me personal questions about what you may or may not have. I'm here to help you understand and to learn about this. And it's fun. This is an enjoyable thing for me and for a lot of people who have chosen to go into the profession of medicine. I hope that this course becomes interesting and is helpful for you, and I look forward to seeing you in the next video.